Good evening, sir. I'll begin the case. This is a case of patient ABC, 64 years old, postmenopausal, housewife by occupation, wife of husband BDC, living in Vadodara, has an income of 3,000 per month, Hindu by religion, and of the upper lower socioeconomic class by Kuppuswamy, modified Kuppuswamy scale. She came to the gynecology OPD with the chief complaints of bleeding per vaginum for 6 months. The patient has been postmenopausal for 8 years. The patient was apparently well 6 months back. Since then, she has had complaints of spotting per vaginum on and off for 6 months. The bleeding episodes were mild, 2 to 3 in number, staining the undergarments only, not requiring any pads. It was not associated with any foul smelling discharge, and there is no history of passage of clots, abdominal pain, or any mass per abdomen. There is no history of whitish discharge or foul smelling discharge, no history of abdominal pain or distension, no history of postcoital bleeding, no history of trauma, ulcer, or surgery in genital tract region, no history of loss of appetite or loss of weight, no history of hematuria or dysuria. There is no history of bleeding per rectum or constipation, and there is no history of any hormonal drug intake.
Okay, yeah, just wait, don't go back. Yeah. So what is basically, Dr. Tejas, what are you trying to rule out by complaining of white discharge, foul smelling discharge, and postpartum bleeding? So what comes to your mind on this?
So the differential diagnosis, once we think about postmenopausal bleeding, the first one is the atrophic vaginitis and atrophic cervicitis. The second one is the three carcinomas, CA endometrium, CA cervix, and CA ovary. And apart from that, there could be foreign body or any hormonal drug intake, hormone replacement therapy, etc. And then there could be also urinary tract or bleeding from urinary tract, which might be misconstrued as bleeding per vagina, and bleeding per rectum, which can be misconstrued as bleeding per vagina. So whitish discharge and foul smelling discharge rule out are signs and symptoms or are symptoms of CA cervix, or it could be an infective etiology. Abdominal pain and distension are for ovarian carcinoma. Postcoital bleeding are any cervical lesions. For example, if there is a CA cervix or a cervical polyp, or a cervical fibroid, then trauma, ulcer, or surgery in genital tract can directly lead to bleeding. Then any loss of appetite, loss of weight is to rule out any malignancy, specifically ovarian malignancy, because ovarian malignancy first presents earliest as loss of appetite and loss of weight. Hematuria and dysuria is for any complaint of urinary tract, for example, any renal stones or any urinary injury or infection, which is leading to bleeding in the perineal region. Bleeding per rectum or constipation, she does not have any bleeding while passing stool or any passage of hard stools, hemorrhoids, or any lesion in the anal canal. And hormonal drug intake, because hormone replacement therapy, if she has been taking, then that might have an effect on the bleeding per vagina.
Okay, yes, so sir. Very good. Yeah, Tejas has beautifully highlighted everything. So what is important that in India, probably the commonest cause of postmenopausal bleeding is cervical carcinoma. So any abnormal vaginal discharge. In fact, we used to joke when, cervical cancer. I remember in LNJP hospital, the name of the clinic was FS clinic, foul smelling clinic. So they say any patient or elderly patient coming to clinic with foul smelling discharge is usually cervical cancer unless proven otherwise. And it was very, very common because of the secondary infection, and although they used to have smelling discharge and same with postcoital bleeding. So we need to rule out cervical carcinoma for this reason. And as Tejas said, sometimes polyp also, sometimes foreign body and all. And any trauma, ulcer, surgery in the dental that he has beautifully highlighted. And any malignancy will have loss of weight, appetite. And yeah, another important thing Tejas has highlighted is hematuria and dysuria, because quite often patients are unable to differentiate between hematuria and vaginal bleeding. They will always say it is vaginal bleeding when actually it is maybe urethral bleeding. So in that case, I mean, the case could be because of polyp or tumor, bladder tumor are also common in India. So they can be the polyp or bladder tumors, this thing can also be there. And another thing, hemorrhoids are fairly common in India also. So any bleeding per rectum, constipation, because that can also be confused by patient as bleeding per vagina. So that's why it's important. And sometimes patient may be taking irregular hormonal therapy like progesterone and all, and then they stop it, and then patient may have bleeding, irregular bleeding. So hormonal drug intake is also important. Okay, then you can go
Yes.
ahead.
Menstrual history. She attained menarche at 13 years of age, and she has attained physiological menopause 8 years ago. Before menopause, her cycles were regular, occurring every 20 to 30 days, lasting for 3 to 4 days, with an average flow, with no dysmenorrhea or no passage of clots. And there is no history, particularly of cervical screening by visual inspection or pap smear or HPV DNA sampling. Obstetric history. The patient has an active married life of 35 years. She has one living issue, P1L1, delivered a full-term normal delivery at government hospital. Is a male of 3 kg, was breastfed for 1.5 years, presently is 34 years of age, and the antenatal and postnatal state during pregnancy was uneventful. She has not had any history of contraceptive use or any history of use of condom, and she has not had a tubal ligation. In the past, in her past history, she is a known case of hypertension for 15 years and is on tablet atenolol 50 milligram once a day. She is not a known case of diabetes mellitus, thyroid disorders, asthma, epilepsy, tuberculosis, or any past history of polycystic ovarian syndrome. There is no history of cardiac illness or renal disease. There is no any history of surgical procedures, blood transfusions, or allergies. And there is no history of breast lump or abnormal nipple discharge. In her family history, there is no history of diabetes, mellitus, tuberculosis, hypertension, thyroid disorders, or any history of malignancies, especially breast, ovarian, and gastrointestinal in the family members.
Yeah, this is the important family history. Why are you asking about the family history of malignancies?
Yes, sir. Because all the three, out of the three malignancies, two malignancies have a very strong ovarian and endometrial have a very strong association have a genetic predisposition. In endometrial carcinoma, there is a syndrome known as Lynch syndrome, hereditary non-polyposis colorectal cancer. It predisposes the patient towards three cancers. One is the colon, that is gastrointestinal cancers, other is endometrial, and third is ovarian cancer. And if a patient has HNPCC, then there is almost 5% chance of having endometrial carcinoma. So a history of breast or ovarian cancer in the and gastrointestinal cancer in the family is a very high risk factor for endometrial cancer as well as ovarian cancer. Especially if it's a breast cancer, then there is called a breast ovarian cancer complex. And again, the genes run in the family. So because of that, the malignancy history should be asked in the family.
Yeah, so this is very, very crucial. I mean, though they are rare tumors, I mean, as a general principle, if it is endometrial cancer and all or breast cancer, the familial cancers are rare, but if there is history in the family, especially as Tejas said, I mean, any Lynch syndrome, any Cordon syndrome and all, so then the chances of malignancy are very, very high. Up to almost 40 to 60% patients in the family can have, endometrial cancer, especially non-polyposis colon cancer or breast cancer and endometrial cancer. So it's very, very high in this. But generally, overall, like if you see 100 patients of endometrial cancer, only less than 5% of them will be familial cancer. But in those patients where there is familial cancer, then the chances are very, very high, 40 to 60%. So that is very crucial. Okay.
Yes, sir. So then
in cervical cancer, usually the family history is not of relevance, but in endometrial cancer, ovarian cancer, breast cancer, it is.
Yes, sir. So should I move forward?
And why? Okay, you are saying diabetes mellitus, hypertension, and obesity.
Yes.
They what do we call that syndrome and why they're related?
Yes. Yes, sir. Metabolic syndrome or syndrome X, it is called. It is basically a accumulation of obesity, hypertension, and diabetes mellitus, central obesity, and dyslipidemia. These syndromes, this metabolic syndrome has a very high predisposition. It's a high risk factor for endometrial carcinoma because the syndrome has hyperestrogenic state, and estrogen is a promoter of the endometrial carcinoma. So a patient who has had polycystic ovarian syndrome, anovulation, metabolic syndrome, where there is a very higher estrogen exposure to the endometrium, have a very high risk for endometrial carcinoma.
they are at high risk of endometrial cancer also being hyperestrovagous. So, carry on.
Yes. Personal history. Her diet is mixed. Her appetite is good. Sleep is sound. Bowel and bladder habits are regular, and she does not have any addictions. Her general examination, she is moderately built and well nourished. Her pulse is 78 per minute, regular with good volume. The BP is 130 by 90 millimeters of mercury in the right arm in supine position. Respiratory rate is 14 per minute, is regular. The temperature is, patient is afebrile. Height is 153 centimeter, weight is 67. The BMI is 30 kg per meter square. Therefore, she is in the type of class 1 obesity. She does not have pallor, icterus, cyanosis, clubbing, edema. Her thyroid examination and breast examination are normal, and her spine is normal. A lymph node examination was done. A supraclavicular, axillary, and inguinal lymph node examination superficially was normal.
Okay, so what is the relevance of the supraclavicular lymph node?
Yes, sir. Supraclavicular lymph node, sentinel, it is a diagnostic feature. It's called Virchow's lymph node. It's a feature for cervical carcinoma. If the postmenopausal bleeding has cervical component to it, then there is a high likelihood that the left supraclavicular lymph node enlargement is more commonly seen with them.
Usually in abdominal malignancies. I mean, more commonly in actually ovarian cancer or other GI malignancies, but can occur in our malignancies also.
Yes.
And if it is there, then it says the patient is stage
directly
4 directly,
distant metastasis, stage 4. Yes, sir. Systemic examination, cardiovascular system, S1 and S2 are heard and there are no murmurs. Respiratory system, there is normal vesicular breath sounds, bilateral air entry is equal, no crepitations, no added sounds. And CNS examinations have higher functions to be normal, normal gait and balance. Abdominal examination, on inspection, the abdominal obesity is present. Umbilicus is central and inverted, no scar marks, sinuses, dilated veins or visible pulsations. No skin changes and hernial sites are intact. On palpation, the abdomen is soft, non-tender, with no guarding or rigidity. There is no mass palpable and there is no apparent organomegaly. On percussion, there is tympanic node present all over the abdomen. On auscultation, bowel sounds are heard. Local examination, external genitalia, mons pubis, labia majora, labia minora are healthy with no discharge. On perspeculum examination, the cervix is smooth, healthy, with no growth, and vagina appears to be normal. Whereas per vaginal examination shows to be uterus to be anteverted, freely mobile, and it is bulky, approximately 6 weeks size, uniformly enlarged. It is non-tender, and bilateral fornices are free. And per rectal examination shows rectal mucosa to be free, bilateral parametrium to be free, and no nodularity is noted in the pouch of Douglas. Investigation.
Sorry, just a minute.
Yes,
go
sir.
back to this. Okay. So, speculum, absolutely. So, I mean, if it was cervical cancer, then definitely would have had finding on speculum examination. So, that the case we have already done. So, in case of endometrial cancer, I mean, speculum examination will be almost completely normal. And as you can see, but sometimes like you could have seen polyp, sometimes endometrial cancer may, may make a polypoidal growth. Sometimes it may come out of cervix also. But otherwise, endometrial speculum examination is usually normal in case of endometrial cancer. But on this, we can sometimes see like things on, I mean, polyp, etc. can be seen. So, and in cervical cancer, of course, we would have seen growth and all. So, we won't discuss that today because it's not a case of cervical cancer, and we have done that case already. Next slide, please. So, on vaginal examination also, many times, I mean, actually, for vaginal examination, endometrial cancer may be actually normal because you won't feel the growth in the endometrium. So, when you are doing bimanual examination, the uterus may be normal, but in your case, like it's about 6 weeks and enlarged, so it can be there. What is the cause of enlargement of the uterus, even if the growth is not that big?
Sir, in our case, there is I mean, apparently in the CA endometrium, the size should be normal, but in this case, it could be that there is a past history of adenomyotic component could be present in this patient, or there could be a presence of any fibroid which is present in the posterior myometrium, which is apparently enlarging the uterus. Because further, the USG findings are also there, which does not support any. Their endometrial thickness is not that much that it supports uh,
Sometimes it may be
increased.
large endometrial growth, or usually
Mhm.
some mucous fibroid or polypoidal mass. I recently had a patient whose uterus was, she had almost 6 centimeters mucous myoma becoming polypoidal growth. Looked like malignancy, but it was benign. Or sometimes large polypoidal endometrial cancer can also make the uterus to be up to 6 weeks size. But sometimes it can be actually pyometra also, like the endometrial cancer
Yes, sir.
usually seen more often
Mhm.
in cervical cancer, but in endometrial, especially if it's the lower part of the endometrium involved, or endocervical sometimes, then there may be pyometra also that can make the uterus very bulky. So, but usually otherwise, I mean, both speculum and vaginal examination tend to be normal in case of endometrial cancer.
Yes.
Well, they will be always abnormal in cervical cancer. And as you said, rectal examination also, that would be again free bilateral parameter and free no nodulity. You will have more findings on cervical cancer actually than on endometrial cancer.
Yes. So investigations.
Yes.
Uh, HB is 11 gram percent. CBC is normal. Serum creat is within normal limits. The coagulation profile is within normal limits. Bilirubin, direct, indirect, within normal limits. SGOT, SGPT within normal limits. ECG and chest X-ray are done, which are within normal limits. Her USG, whole abdomen and pelvis was done. The uterus was found to be bulky. Endometrial thickness was 15.6 millimeters. Poorly differentiated endomyometrial interface is seen. Bilateral adnexa are normal, and there is no free fluid in the pouch of Douglas.
Very
On
good. So
endometrial,
just stop here. So the ultrasound scan is extremely crucial. In fact, the first line of investigation always any postmenopausal bleeding, we need to do ultrasound scan done on them. And here, in your case, it is quite clearly. But they just to the dear students, I mean, would you like to say what is the latest ACOG guideline about endometrial thickness? I mean, when
yes,
can
sir.
we avoid doing endometrial sampling, and when we need to do endometrial sampling?
Yes, sir. So any postmenopausal patient, the first investigation is transition sonography, one of the first investigations in which we find the ET. ET earlier was the cutoff was said to be 4 millimeters, but the recent ACOG guidelines have shifted it to 5 millimeters. So any endometrial thickness which is beyond 5 millimeters should be taken up further for endometrial
Including
biopsy,
5 mm, including 5 mm.
including
So
5,
5 mm
5
is
and more
absolutely.
than 5. Yes, sir. So 5 and more than 5 should be taken up as suspicious and should be taken up as, for endometrial biopsy. And the reason for 5 is that it has been found out in through further studies is that if it is less than 5 then the risk of endometrial carcinoma in the endometrial thickness is less than 0.5%. And if it is more than 5 then there is a very high sensitivity in the endometrial biopsy. So,
So any condition so normally, so less than 5 mm, then we don't do endometrial sampling on them, isn't it? But is there
yes.
any condition when even with less than 5 mm, we have to do endometrial sampling?
Sir, if there is any visible endometrial mass which is seen inside for example, there are two type of masses which we can find out. We can use Doppler for the same. So if there is a homogeneous mass which is present, which has diffuse vascularity, or if there is presence of intracavitary fluid, then in such cases, again, even if the endometrial thickness is less than 5 the endometrium is still suspicious. So again, endometrial biopsy we can go for endometrial biopsy.
Or
There is a
sometimes
recent,
if the patient has got recurrent postmenopausal bleeding, like the and thickness was say 3.5 or 4 mm and all, and we thought we'll wait and all, but she's having bleeding again, repeated bleeding, then also we should do endometrial sampling.
yes. And
And in your case, the findings are quite clear. Endometrial thickness is 15.6 mm, and that also some student also wrote after 8 years of menopause. I mean, she's not into. And menopause, when do you define that menopause is at least
one
at
one
least 1 year post?
1 year of
And then you have got poorly defined endomyometrial surface and isn't it bilateral? So that also goes in favor of endometrial. Sometimes you can see polypoidal, like, growth even on ultrasound scale. And in your case, endometrial biopsy has already been done. So suppose this patient came to you at this level only. So what will be your next step then? I mean, we haven't done endometrial biopsy yet. So suppose these are the ultrasound finding, your patient. So what should be the next step? Should you do only endometrial biopsy or something else like?
Sir, for a patient which has endometrial thickness of 15.6, the first thing we would definitely go for is endometrial biopsy only. But there are various methods of doing the endometrial biopsy. The first one is office endometrial office aspiration, in which we can use a pipel or we can use a Novax curate, and we can do it in the office. It requires a minimal sedation, and with tablet misoprostol kept in PV, effective dilatation is also achieved. But the second step, of course, is doing dilatation and curettage, in which a misoprostol tablet is kept, sedation is given, and with effective dilatation, the entire biopsy is taken. And if possible, and always advisable, endocervical curettage is also done. And the third, of course, is fractional curettage, which is hysteroscopy guided biopsy, where a office hysteroscope or a hysteroscopy in the OT is done, and only the suspicious regions are specifically biopsied for further evaluation.
So should the histoscopy be done in a suspected endometrial cancer or not?
Sir, hysteroscopy.
I mean, what were the risks? What we have been they have been studied in the past. Though recently the studies have been refuted. Why do we avoid histoscopy in suspected endometrial cancer? But the recent study do say that we can do it.
Sir,
what can happen in endometrial cancer if you do histoscopy?
If the endometrial cancer, because of the fluid which is being used as a distension media, there is one of the studies definitely shows that there is a possibility that the deposits, there can be extravasation of that there can be hematogenous spread as well as direct spread of the of the cancerous deposits. And
yes. So when we put histoscopy fluid under pressure, actually, so that's why you need to use lesser pressure, but it will go through the fallopian tube, just like as if you are doing histoscopy, as if you are doing dye test, something like that. So that fluid goes, so that will take endometrial cancer cell through the fallopian tube into the peritoneal cavity, and theoretically it can spread the cancer. But the research, there were studies in the past actually for that, and that's why some people hesitated to do histoscopy, and instead we should do endometrial sampling and all. But the recent studies show that usually the peritoneal macrophages and all, they actually will prevent it, and then even if the malignant cells do go there, they don't normally cause. I mean, the prognosis is not affected, and even staging does not affect. It's not that even if some cancer cells do go there, they will not actually implant the macrophages system. I recently heard a lecture also by some eminent oncologist, and that they say can be done. But I think for exam purposes, some examiners may be a bit skeptical. So you can actually say, as they just said, at the pipel, what is the sensitivity and the specificity of pipel?
Sir, I don't remember the sensitivity and
it has got very high sensitivity. People has one of the highest sensitivity and specificity, because you can take it. Yeah, someone said 99%. Yeah, almost. Yeah, it has got a sensitivity of nearly. Let me just check. 99% sensitivity, 98% specificity. So people is 99% sensitivity and 98% specificity. While and the others, I mean, the other alternative in India, the people is slightly more expensive, may not be available in all the centers, but that is the highest, and without, you don't even need any dilatation for doing people test. So Carmen's cannula can also be, like Tejas said, number 2 to 4 cannula, and that is very cheaply available. That can be done. Fractional curettage, as Tejas said, was very, very popular in the past when we were students. We were usually doing. At that time, we thought that we would take sample from entry wall separately, posterior wall separately, lateral wall separately, fundus separately, like that. 4 or 5 samples and one endocervical curettage. So 5 or 6 samples were taken separately in separate bottle. But now the studies show that it doesn't make any difference in the prognosis. I mean, whether it's from entry wall, posterior wall, lateral, doesn't make any difference, and prognosis not. So that's why fractional curettage is no longer done. It was much bigger operation, you know, you would take so many specimens. So these days, the office procedure, as Tejas said, PPL is number one, and of course, Carmen cannula is the second best choice if you don't have PPL. So that is what actually we should be done. And histoscopy, though, in case of suspected endometrial cancer, many people would avoid doing that. But recent study do show that it doesn't. I mean, an advantage of histoscopy that you can directly visualize the endometrial cavity. You can clearly mention where the growth is, and you can take biopsy under from the area where the growth is there. Okay, and then sometimes you can see the polyp, you can see any other findings also, atrophic endometritis and all. But some older studies did show that endometrial cancer cells will go through the fallopian tube and they can get implanted in the peritoneal cavity. The stage will increase. Though recent study do show that it doesn't change the prognosis, and those cancer cells, even if they go in the peritoneal cavity, they are taken care of by peritoneal macrophages, so they will not cause spread of the malignancy. But still, some examiner, from exam point of view, I think the student can be very, like, you have to be careful in exam. I don't know the examiner coming to you for DNP or DMM exam. They may not be actually doing histoscopy in a case of suspected endometrial cancer. So you can be skeptical. While you are answering, you can say that my best choice will be PPL or Carmen's cannula and this thing. But histoscopy can be done. Recent studies do show that doesn't increase. So that knowledge should be there with you, but you have to be careful because the examiner may not have come prepared with that answer, and some examiner may not accept it that no, don't do histoscopy which is suspected endometrial cancer, because some older studies did show that cancers can spread theoretically. So you have to be smart in answering the question depending on the situation in exam.
Yes.
Okay. Aditya, you want to say anything about it? About this point, histoscopy in endometrial cancer suspected?
No, sir, no, sir. Given my very little experience in hysteroscopy, I would really not want to add anything more than that you have added. You have almost spoken everything about it.
Okay, thank you. Okay, so they just did endometrial biopsy and the CST of endometrial carcinoma, endometrioid adenocarcinoma grade 2. So maybe Tejas, you want to say a little bit about endometrioid adenocarcinoma and other like clear cell carcinoma and all, little bit about them, how common are they and which has got better prognosis?
Yes, sir. So depending upon the histopathology, the endometrial carcinomas have been defined as endometrioid endometrial carcinoma, then mucinous, clear cell, papillary, serous carcinoma, squamous carcinoma, undifferentiated carcinoma, mixed carcinoma, etc. Out of this, majority of cases are endometrioid carcinoma. In that also there are certain variants. They were earlier defined as villo-glandular, papillary, secretory, squamous differentiation, etc. So the most common is endometrioid adenocarcinoma, and endometrioid adenocarcinoma, because it has a very early presentation because of its increased higher bleeding rate. So because of that, it has amongst all the other histopathology, it has a better prognosis as compared to the other carcinomas, other histopathologies. And then the grading system is done for endometrioid carcinoma. Grade 1, 2, and 3. The grade 1 is how much of it is involved. So if it is less than 5% involvement, it is grade 1. If it is 5 to 6 to 50% involvement, it is grade 2. And if it is more than 50% involvement, it is grade 3. And the grading is done because it determines the prognosis and it also determines the modality of treatment. And if fertility preservation is required, then also grade is important. So that is done. And further, classification, there's a very old and classification known as type 1 and type 2 classification of endometrial carcinoma. Type 1 grade 1 and grade 2 mainly come under type 1 endometrial carcinoma, and grade 3 usually goes into type 2 endometrial carcinoma. And 80% of the cases are type 1 endometrial carcinoma. It is where the endometrial thickness is increased because it's an estrogen dependent condition. Whereas type 2, the endometrial thickness might not be increased. The endometrial USG might show an atrophic endometrium, but there will still be endometrial carcinoma. So much so that, and it is because the endometrial bleeding is not that much. About 50% of deaths in the case of endometrial carcinoma occur in type 2 carcinomas. And type 1 are caught early, so they are treated better. And apart from that, so type 1 has a favorable prognosis, and uh, the type 1 is estrogen dependent, whereas type 2 is it is not estrogen dependent. And then the molecular uh, the genes were found out which cause type 1 and type 2. So type 1 is mainly caused because of P10 gene mutation, microsatellite instability, and KRAS gene mutation, whereas type 2 is caused because of P53 gene mutation, P16 mutation, and E-cadherin mutation. And now we have further classification on the basis of which is called the molecular classification, which again classifies the endometrial carcinoma into low grade and high grade. So there are certain mutations like pol E gene mutation, the epsilon, polymerase epsilon mutation, and microsatellite instability mutations. So polymerase epsilon mutation has a more favorable prognosis. Microsatellite instability mutation like MLH1, MSH2, MSH6, they have a less suitable, less favorable prognosis. And then there are two types of groups known as copy number low group and copy number high group. Copy number low group has a more favorable prognosis, they have the mutation NSMP, non-specific molecular profile, whereas copy number high group have P53 abnormalities. They have a higher, uh, uh, less favorable prognosis. So, sir, overall, if we try to see, there are two classifications of endometrial carcinoma. One is histopathological, another is molecular. And with the recent one, which is the molecular classification, it is affecting the, it is all the recent guidelines are recommending molecular classification because it helps us to change the treatment modalities and give a better outcome to the patient.
Absolutely. So this is very, very important that this molecular classification has recently been added in the literature. So the students should read that, and Tejas had beautifully highlighted that. And Tejas, had there been some change in the FIGO classification also of endometrial cancer?
Yes, sir.
Recently?
Yes, sir. So the past FIGO classification was FIGO 2009 classification. So the FIGO 2009 classification is that there is stage 1. Stage 1 is limited to the endometrium. 1A is less than 50% of endometrium involved. 1B is more than 50% endometrium involved. 2 is when the cervix is involved. 3 is when it goes beyond the uterus, which is up to the serosa or adnexa. That is 3A. And cirrhosis and agnosia, that is 3A, and 3B is when there is vagina is getting involved. Whereas 4 is when there is distant metastasis. 4A is to the bladder and the rectal mucosa, and 4B would be when there is involvement beyond the bladder and the rectum. But now the 2021 classification has come in. The 2021 classification has further put in the
it is 2023. Someone said, yes, I
sorry.
also.
Yes, sir. 2023 classification, and that classification has further put in the grades into the endometrial carcinoma. So the low grade and high grade. So each of the 2009 classifications have been classified as low grade and high grade, and grade of endometrioid carcinoma. Yes, sir.
Yeah, absolutely. So we won't go into much detail. I mean, all students are required. Please do download it. It's easily downloadable from FIGO website and otherwise also in the book. So you remember 2023. So grossly it remains same, but they have further sub-classified like 1A1, 1A2, 1A2 like that. They have made it, and as Tejas has said, it has included other aspects of that. So you should, all of you need to, because the classification is detailed, and if you start doing that, that will take itself 1 hour. But you need to know that classification also in detail, and that you can be asked about it in exam, very commonly asked in theory also as well as in practical exam. Okay. So now, Tejas, how will you manage your patient? Now you got, so according to this thing, which stage, FIGO stage will be your case? You got the finding of your case.
Sir, yes. So, sir, before staging, the staging of this patient would finally done using would be surgical staging. So, surgery would finally diagnose. But from clinical picture, we cannot find that there is invasion beyond the sorry, there is metastasis beyond the uterus. So, it will definitely come under grade 1. But how much myometrium is involved, that will define if it is 1A or 1B. But the so it will be stage 1. 1A or 1B will be on the basis of surgical staging. So, sir, further we are going to plan her for an MRI so that we have a better picture before going into surgical staging as to what is the soft tissue involvement in this patient, and then we will go for a surgical staging for this patient. And the further surgical management for this patient would be we do a extrafacial hysterectomy with bilateral salpingo-oophorectomy. And apart from that, we will do a pre and para-aortic lymph node dissection and a thorough abdominal inspection as a surgical staging protocol. And then we will stage this patient. And if required, most likely we will go for a post-operative radiotherapy protocol.
Yeah, that will depend on the histology. I mean, you will send your
Histopath.
total hysterectomy specimen with bilateral salpingo-oophorectomy, with extrafacial and with pelvic and para-aortic lymph node. So depending on the report of that, then you will decide. And when will you give post-op radiotherapy if the myometrial involvement is?
If it is more than 50%.
Yeah, if it's come to more than 50%. Sometimes, I mean, usually MRI, as you said, followed by surgical staging, may detect it, but ultimately the histopath report has to be seen. So if it on that it comes to more than 50% and what type of it is, then we need to give radiotherapy to the patient. But if it's less than 50% lymph node are negative, then we can skip radiotherapy. So
Yes.
In this case, there is a chance that it is chances that it may be probably more than 50% myometrial involvement, especially. And MRI also can detect that, but will depend on the histopath report. And what route will you take to do surgery? Laparoscopy or robotic open, and which incision?
No, sir. We will go for an abdominal hysterectomy. That is a laparotomy only. And we will give a midline vertical incision because it is best for surgical staging.
Yeah. So for dear student, as Tejas said, I mean, at your level, you will be appearing in MS, MD, DNB, DGO exam. So in that case, I mean, you're not appearing in MCH exam. So you should restrict. Best answer will be vertical incision, and so that we can do complete surgery. Though some people can do laparoscopically also same thing. They can do because TLH and they can do pelvic and para-aortic lymph node also laparoscopically. But I think at your level, the best answer will be, okay, I'll give vertical incision so that we can do the para-aortic and pelvic lymph node also and properly see it. Because what they are asking in exam is how will you manage, not how will some expert, like someone robotic surgeon, good robotic surgeon, some onco robotic surgeon can do that also very well. So, but you should be aware. Some the examiner may say you will rest. I mean, you will be do only vertical incision. Can we do robotically? Can we do laparoscopically? So the answer should be, I will myself do this, and that is how my consultant in my hospital does. But yes, I know that it can be done by laparoscopy route or robotic route also. And but aim is that we do complete surgical removal. I mean, extrafacial total hysterectomy with bilateral salpingo-oophorectomy and with pelvic and para-aortic lymphadenectomy. So that is to be done. And Tejas, if it was a case of clear cell carcinoma, one of those rare types, which are more type 2 type, right? Then how do you manage her?
Sir, then clear cell carcinoma in the case of
core carcinosarcoma, mixed Mullerian tumor is now called carcinosarcoma. So some of them can be carcinosarcoma. Also, what we used to call mixed Mullerian tumor in an older classification.
Yes, sir. Sir, so if there is a clear cell carcinoma in the endometrium, then the management, there would be, patient would have a much poorer prognosis. First of all, the patient will come late to us, and there might most likely will be a metastasis before the patient comes to us. So in such situations, there is a role of doing a neoadjuvant radiotherapy in such patients, and then proceeding towards the yeah, towards the surgery. And immunotherapy has also been proven to play some role in the case of clear cell carcinomas.
So in that case, extra will be the malignant is almost like ovarian cancer. In these patients, extra surgery, what you have done is fine, vertical incision, everything same. Plus, we do intracolic omentectomy also.
Intracolic omentectomy.
So that
Yes.
is the extra this thing. Tejas, do you, Dr. Aditya, do you agree? Okay. Yeah, so basically we need to manage them like ovarian malignancy. So you need to do along with, apart from surgery done for endometrial adenocarcinoma, we need to do infracolic omentectomy for clear cell carcinoma and carcinosarcoma. That is different.
Yes, sir.
And as they just said that post-operative, then we wait for the histopath report, and if it turns out to be more than 50% invasion, then you said we have to give radiotherapy to these patients also for that. Okay. Okay. So your patient is postmenopausal, but just for the sake of this thing, Tejas, so is there any, not in your patient, but if your patient was a 35-year-old, these days we are seeing younger patients also. Previously, less than 40 years, endometrial cancer was almost unheard of. It was exceedingly rare. But recently, we are seeing patient in 32, infertility patient also, and in PCOS patients, even without completion of their family or no issue, some of them are having endometrial adenocarcinoma. Suppose you got a 32-year-old patient and she doesn't, infertile patient, and it turns out to be endometrial adenocarcinoma, early stage. So
Yes,
can
sir.
we do fertility sparing treatment for them?
Yes,
and
sir.
what is that?
Yes, sir. So, as you rightly said, sir, that it is not a very common scenario. Less than 10% of endometrial carcinomas they occur in women less than 40 years of age, but fertility preserving surgery is reserved only for a few set of women. One, she should be nulli gravida. Second, she should have a well differentiated early endometrial carcinoma, possibly ideally stage 1A only, that is involving less than 50% of the myometrium, and ideally grade 1, not even grade 2 or 3, because that the risk factors increases. And in all of these cases, we are basically going to give her progesterone therapy till she to reduce the tumor burden, and then allow her to conceive. And after conception and successful delivery, we go for a hysterectomy in the postpartum state. So the progesterone that we give is high dose medroxyprogesterone acetate, 600 milligram per day is given orally. And megestrol acetate can also be given, 160 to 320 milligram per day orally is given. And these are the oral medications.
And
LG
you will
can
follow
also
them
be
up. So
given.
you have given her MPA or this thing, and then will you follow her up after 3 months
Yes,
or
sir.
6 months and with
Yes.
endometrial biopsy?
Yes, sir. Endometrial sampling has to be done every 3 monthly to assess the response to the treatment. And pregnancy rates of approximately 40% and live births of approximately 50% have been achieved in such case reports. But sadly, there is very high
But if
recurrence
repeat
rate.
histopath shows that malignancy is still persisting, then we may have to abandon this, and may have to go
Yes.
for surgery. Usually with high dose progesterone, the endometrial cancer disappears temporarily, and then at that time, then we can try for conception, as they just said, with good results. Right? But if the malignancy persists after, is it 3 months or 6 months?
Sir, to best of my knowledge, it is 3 monthly. We have to
3 monthly. 3 monthly we make.
Yes, sir.
So we had a patient in named, I remember, she was 30-year-old from Faridabad, I recall her. And then we had given her this dose, and then after 3 months, it disappeared. And then she tried for conception. Unfortunately, she didn't conceive in next 6 months, but we were waiting for that. So we can even try IVF and, sometime all this in these patients. But generally, as someone said, disclaimer and all. So in exam purposes, because most of you are like, DNB, DGO, MD, MS. So at that level, not MCH exam. We are not talking about MCH exam today. So in that case, I mean, your traditional answer should be complete surgery, and that is very rare. But you should be aware that yes, if the patient examiner specifically asks you about this question, then only you like start this discussion. Otherwise, avoid. Okay, so traditionally, I mean, in a case of malignancy, serious malignancy, we should do surgery. We shouldn't be, leaving a malignant uterus inside. But yes, rarely young patient, infertile patient is willing. So this has been done with high dose of progesterone, but with strict follow-up after 3 months. And if endometrial biopsy shows negative, then only she can try for conception. If malignancy remains, then we need to do surgery for them. Ideal treatment is complete surgery, not follow-up. But this can be done. So exam, you have to be smart enough to answer the question, because some examiner may not like the answer. That they may say, well, it's a malignant patient, you will leave, so that they have to, you have to be take care of those examiners also. So your answer should be that yes, this is how I'll manage, but this treatment can be done in selected patients under guarded this thing. We need to follow this patient. It's not that we started MPA and then patient, we lose the patient on follow-up and later on she develop disease progresses further and she may die of the disease. So you have to answer your question, I mean, in a smart way. That is very, very important, because I can't answer you like anything, because I don't know how the sequence of questions go in exam. So you have to be smart enough to say that. So generally, you say that this is the treatment that will do complete surgery for this patient, irrespective even if they are younger. That is my priority for. But yes, in selected patient, it can be tried in fertility patient under supervision and follow. And that is also like as someone said, with a disclaimer only, not routine. Okay. Any role of okay, you have already said that role of high. Any other role of this high dose progesterone in which type of patient? One is young patients.
And sir, yes, sir. And other where we can be using it as a hormonal therapy, as a part of chemotherapy. So it can be used in the cases of recurrent endometrial carcinoma. So in that, hormonal therapy is recommended for endometrioid histologies, especially when it's ERPR positive, or so there again progestational agents can be used.
Very sick patient, very elderly patient, very distinct. Sometimes the patient cannot, they're not, suitable for surgery. Recently, we had a patient like, she had stroke. She's normally 84-year-old, and she had many other comorbidities and all. So the patient's attendant and all, they refused any treatment for her, and she was having repeated bleeding. So I have put her on high dose of progesterone, and she has responded to that. So that is just like, but it's not a standard treatment, again, as selected patient. So what as Tejas said, so even high dose progesterone works like a chemotherapy for these patients. So those patients who are very moribund, who cannot be taken up for surgery, who have other comorbidity, very less likely left, so then high dose progesterone will work like chemotherapy and will be like, just like in infertility patient we gave. So same way, rarely we can use here also. Okay. And otherwise, I mean, the treatment remains surgical treatment, the treatment of first choice. And so, any other point, Dr. Aditya, you want to say any other thing which we have missed?
Can we cover atrophic vulvovaginitis a bit, because that is in fact one of the commonest causes of postmenopausal bleeding that a lot of residents don't know how to treat. So could you just give us an overview of what are the drugs that you prescribe and what is the ideal way of managing these patients?
Which postmenopausal patient or endometrial cancer?
Atrophic vulvovaginitis, sir.
Atrophic vulvovaginitis. Oh, sorry. Okay. Yeah, very good question. So because
few
most
drugs
of them,
that you
as
prescribe.
Dr. Aditya said, most of them will not turn out to be endometrial cancer or cervical cancer. So really, so that's why, I mean, once we have done endometrial sampling, or if we have done endometrial sampling on them that shows atrophic endometritis, or the endometrial thickness is less than 4 mm, 5 mm, we now take it. So then we can just follow these patients. We don't need to give the treatment. But if they are having other urogenital atrophic symptoms, then sometimes we can give topical estrogen, but not oral estrogen, not to be given to them. So that is, and we can just follow these patients up, and usually they get better. But topical estrogen can be given to them in the form of this, Primarine, Avalon 2 creams are available. So initially we give them daily for a week or 2 weeks, and then twice to thrice weekly for next 3 to 6 months can be given. And we can follow these patients. So sometimes I've seen patients with atrophic vaginitis, atrophic, and even some they have dysuria also because of urogenital atrophy. So estrogen is important component of urogenital epithelium growth and area. So when they have dysuria or very thin vagina, they have recurrent vaginitis and supraedit because of thin endometrium and thin vagina. So we can give them topical estrogen therapy that will work more on vagina than on endometrium. But some amount is absorbed and that works on the endometrium also, and some amount is absorbed and that will work on uroepithelium also. But I mean, daily and long term you cannot give because that can itself cause endometrial hypertrophy and endometrial carcinoma rarely as this thing. So you have to be careful. So if you are using it for long term, then you have to combine with progesterone. Otherwise, topical estrogen, that's why we never give it daily after 1 week or so. I use it, but like twice weekly only, topical. So that's careful. Otherwise, it will be absorbed, and even that can cause endometrial hypertrophy and rarely endometrial carcinoma. And I think one point we have missed is about tamoxifen. Tejas, if some patient has been on tamoxifen, what is the follow-up of these patients? Because they can also develop postmenopausal bleeding and endometrial cancer. So what is the regimen we follow?
Yes, sir. So, sir, the patient who has tamoxifen basically is a selective estrogen receptor modulator. It has agonistic antagonist action on the breast cancer, so it is used for ER/PR positive breast carcinoma, but it has an endometrial proliferative action, because of which it causes endometrial hyperplasia and polyps, and it basically has so. Therefore, a patient who has breast cancer along with tamoxifen should be followed up as a screening protocol with endometrial biopsy. Even perimenopausal, premenopausal, whenever it is, she should be taken up for endometrial biopsy. She should be taken up for a yearly history along with transvaginal sonography and pelvic examination and endometrial biopsy, as long as she is on tamoxifen.
Yeah. So this is very, very, very important because tamoxifen can cause endometrial hyperplasia, can cause endometrial carcinoma. So need to know this guideline in exam. The examiners are often asking this question these days. And breast cancer is becoming so common. 1 in 10, rather 1 in 8 women are having breast cancer these days. So you are getting many patients on follow-up of tamoxifen, and then they keep on having postmenopausal bleeding. And we need to know how to manage these patients. What should be the follow-up of that patient? So I think, yeah. Okay, someone says Pirov mentioned no routine biopsies for them. Yeah, biopsy to be done in selected patients only of tamoxifen, not routinely. That's so. I mean, I think the thickness of endometrium we have not routinely. So I think we have covered almost all aspects of it. Anything if we have not covered, then we can mention about it. But I mean, endometrial adenocarcinoma is becoming very common in India also
No, sir,
now.
I think we have covered.
I remember, I mean, when I was a resident, we hardly saw any case of endometrial carcinoma. Cervical cancer used to be number one, ovarian also used to be there. Now it is in India, it is number one cancer in Western countries, and in India it is number 3 cancer. So it is becoming common. But the good thing is that, as Tejas said, that prognosis is excellent, especially for endometrial adenocarcinoma, because it is manifests in early stage with postmenopausal bleeding and then. So prognosis, I mean, what is the 5-year survival rate of grade 1 endometrial adenocarcinoma?
Sir, it's pretty high. It is approximately 75 to 80%, if I'm not mistaken.
Almost 85 to 90%. Yeah.
85 to 90%.
So, yeah.
Yes.
So in fact, I remember one of the gynae doctor was, giving a talk, and she said, if God appears in my dream and has that I have to have one malignancy, so I'll opt for an endometrial carcinoma. It has such excellent prognosis. Not that we want malignancy, but it is one of the best that way malignancies to have. In a way, it has got excellent prognosis. And I know many consultants and all who have been having it 20 years back, and they are all 5 feet and healthy and going well. So that it has got a good prognosis. But of course, endometrial carcinoma, breast cancer, fibroid, endometriosis, all these are hyperestrogenic states, and They're becoming more common because of more obesity, more hypertension. As they just said, corpus cancer syndrome. So obesity, hypertension, diabetes, that is a corpus cancer syndrome. They are high risk for getting, and we are getting so many obese patients these days. Diabetes is becoming so common, hypertension is becoming. So we have to be careful in these patients.